this situation where a patient is being denied some type of service in healthcare or denied the payment for that service by their health insurance, wow, that's just really something that is misunderstood, I think. And also, in some cases, maybe the payer policy isn't as good as it could be. I don't really know. But talk about the application of AI on this issue of denials management. And then let's drill in a bit into that as far and broad as you'd like to go on how we should think about that as consumers of healthcare in the United States. Because obviously it's something that there was a lot of underlying angst that wasn't really being communicated through the biggest megaphone that it is now. But how can AI be applied to this denials management issue, and where does it go wrong? Where can it go right? Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Hello, everyone, and welcome to our next episode of Boombostic Health. I'm incredibly excited and appreciative of my good friend Brian Norris joining here. Brian and I have known each other for a number of years, growing up through the health tech scene in Indianapolis. Yeah. He is the head of strategic consulting for MedeAnalytics, a firm that I don't think is as widely known as what it probably should be, given that it's been around for a few decades, making a huge impact on healthcare delivery. But we're going to learn more about that from Brian. Just to give a little background, Brian has over 20 years of experience driving innovation at the intersection of healthcare technology, value-based care, and advanced analytics. He has a particular expertise in the application of artificial intelligence, which we're going to talk about specifically. As Vice President and Managing Director of Strategic Consulting at MedeAnalytics, Brian leads a team focused on helping organizations navigate the complexities of value-based care, optimize performance with data-driven strategies, and achieve meaningful improvements in healthcare delivery. Brian, welcome to the podcast.
Awesome, and thanks for having me. I'm really excited to be here, Brad.
So specifically, talk to me a little bit about what inspired you to get into healthcare, and then also maybe in your own words, introduce where it is that you see yourself focusing on a daily basis. And then ultimately, the topic we're going to dive into is the application of AI, and in particular on denials management, which is a massive flashpoint right now, given the tragic death of the United Healthcare CEO of their insurance unit. So give us a quick introduction and talk to us about, why are you in healthcare?
Yeah, thanks, Brad. So I got into healthcare probably about 25 years ago. The reason for my why into healthcare really started when I was young. My grandmother migrated from Costa Rica to the United States, had a second grade education, spoke 5 languages at the end of the day, but worked as a kitchen supervisor for Lutheran Hospital in Fort Wayne, Indiana, the old Lutheran Hospital before the new one was built. And whenever we would go visit...
This was your grandmother?
My grandmother.
Okay.
Yeah. When we would go visit her, my brother and I would go down to the cafeteria and have lunch with my grandmother. And so we were frequently visiting my grandmother. And so I got exposed to healthcare at a very early age. And so when I came out of high school and was kind of thinking about what I wanted to do, I was like, man, healthcare seems like a great opportunity. Fast forward into, the years after, as I was going to school, I spent a lot of time shepherding her around. She didn't drive, so somebody had to take her to a doctor's appointment. She had chronic kidney disease, she had lung disease, and so I spent a lot of time shepherding her to this specialist or that specialist or her primary care doctor. And I just saw the inefficiencies of healthcare. And I was either going to go technology because I love computers or go into healthcare. And so I decided to go down the nursing route. And then from there, expanded my skill set into more of a CS skill set. And then went back for an MBA in business. And so it's been a great ride. I mean, my why really started with her in terms of seeing the inefficiencies of healthcare, seeing the opportunity to maybe come in and make an impact.
Right. That's awesome.
Yeah.
I bet your grandmother would be fascinated to see the whole food as medicine movement.
Yeah.
Given
I love the
background.
food as medicine movement. And we can talk a little bit about that. We're doing some things in that space as well. But, back then there wasn't Uber Eats and there wasn't DoorDash. It was hard to get healthy meals into the home, especially for those dealing with chronic disease. And there wasn't a lot of investment in it. And so, today we have more data, we have more knowledge, and we have more tools.
Right. I bet your grandmother has she passed away?
She passed several years ago.
Okay. Well, I'm sure she'd be proud of the work that you're doing, and hopefully she got to see some of that as she was still with us.
Yeah.
That's great. So, Brian, with respect to your focus at MedeAnalytics and just what MedeAnalytics does, like I said, it's one of the most impactful unknown companies out there. It's a name that sounds like I should know what that is, but what does Medi do, and how does your consulting group relate to the overall strategy and vision at Medi?
Yeah, thanks. So I've been with Medi a little over a year now. When I got introduced to MedeAnalytics, I was introduced through a friend that worked with Medi. And I honestly had no idea who they were. They started off 30 years ago, really focused on the revenue cycle space. So front, middle, back, workflow driven. And that business today still powers a lot of organizations. So today, MedeAnalytics is utilized to help optimize the registrar process in the front office of a provider. It's used to optimize, revenue cycle on the back end and moving claims around. And we'll talk a little bit about the denials management space. But over the last several years, the opportunity, and as you think about the advancements in both machine learning and data analytics, and then where we're at just from an organizational standpoint and for value-based care, the opportunity was really there to get more breadth into quality management, clinical management, really helping with some of the more meatier problems that I'll consider across all threads of the healthcare ecosystem, whether it's a payer or a provider or your life sciences company. And so Medi today really, our core offering is really our health fabric, and that enables us. And what my team does is we leverage data out of that health fabric to really optimize processes. So, for example, how that shows up, maybe you're a Medicare Advantage plan and you're trying to figure out how best do I serve my chronic disease populations, but then the rest of my Medicare populations as they're growing. What services do I need? What opportunities might I have in the SDOH space? How do I show up? How is my population doing? What opportunities do I have? The questions are sort of endless that you can ask of the data, but then taking that and operationalizing it. So Medi today is really a value-based partner in analytics to payers, providers. Some of the largest payers in this country are powered by our technology and our services, as well as some of the largest healthcare systems.
So some people say value-based care isn't really happening. It's this idea, but healthcare's too complex. And I deal, as you know, a lot on the lab side with our company HC1 that I run.
Yeah.
And we're seeing day to day how what we can do to optimize diagnostics, it flows downstream to make it so healthcare is more effective and costs less. And that's what value-based care is all about. But I'd love to hear your point of view on how big is this value-based care thing, and is it real? Is it happening or not?
Yeah, that's it's interesting. Every day I'm having conversations about quote unquote value-based care, and it means something different to everybody, right? On one hand, a group is focused on the definition of value-based care being, is it fee-for-service revenue? Am I paying for that on an individual unit or widget level, or am I paying for it on value? Others look at value-based care as it's a journey, and there are things you should be doing to optimize the healthcare dollar, but also outcomes. And in that case, you have good fee-for-service revenue that can enable a value-based care approach. And so we tend to focus on the latter. So an example of that is if you're an ACO and you're caring for Medicare lives and you're at risk to reduce costs, some things you can do on the fee-for-service side are do that annual wellness visit, address those advanced directives, get those annual labs to understand where they're at from a bio standpoint, enable good quality care management for your for your chronic disease management patients. All of that has a fee-for-service aspect to it that provides the rocket fuel for those providers to be able to offer and continue to offer those services. At the same time, things like looking at your genetic profile on labs might be a good thing to do. Maybe you don't want to do that on 100% of the population, but you might want to do it on 20% of the population where it makes sense to get to more personalized care and more personalized medicine.
As you know, that is something that's near and dear to my heart because of our company DecisionRx in the Health Cloud Capital portfolio that is focused on optimizing people's outcomes based on taking the right medications.
Exactly.
And there's this kind of genetic test called a pharmacogenetic test that doesn't get paid for in a fee-for-service paradigm, but it can dramatically improve somebody's outcome when they're on the right meds that are compatible with their genetics. So is that an example that is relevant?
It's exactly an example. So if you look at like mental health space, behavioral health is becoming a very hot topic for a lot of reasons. And there's not enough providers to care for the amount of us that have some form of depression, anxiety, or some behavioral health issue. There are many, many different pharmaceutical treatments out on the market. There's a genetic test that can be done to tell you if you're getting treated for depression, which medication might work better for you based on your genetic profile and based on your absorption and many other factors. Often that test it costs a couple $100. It's actually a couple thousand by nature. Oftentimes once insurance kicks in, it costs a couple $100. Most people can't afford that today. But what it saves is time trying drugs that might not help your situation. You may not have your depression reversed. Your anxiety might get worse. If you're schizophrenic or have, deeper level mental health issues, it's a try-fail scenario. Oftentimes in mental health treatment, we're wasting significant amount of money on, hey, Brent, try this pill. 60 days later, it doesn't work. Try this other pill.
Trial and error.
Hey, try this other pill.
I say people should not be treated as guinea pigs if you can avoid it.
Correct.
In terms of experimentation.
Correct.
So really cool that I'll just summarize it as MedeAnalytics is driving improvements in clinical quality and outcomes by not just identifying these signals through analytics, but also putting them into motion through workflows that solve the problem, that close the gap. So make sure you address the person who's high risk, and so they get a better outcome, and ultimately deliver on the promise of better healthcare for patients in a way that's also economically supportive of the mission, business-wise, of the healthcare system.
Exactly.
Yeah.
One of our areas that we talk about all the time is the concept of managed action. And oftentimes, as being in the healthcare data and analytics space for a long time, you can provide an insight to a clinician, to an operator, but unless they put in the people and process and the surrogate measures and the way that they're actually going to manage that change, oftentimes the outcome becomes subpar to where they wanted.
Got it.
And so being able to see, track, manage, coordinate, collaborate is essential across the health system. And so part of what we also offer on top of our analytics is a platform we call MedeAchieve, which allows organizations to build playbooks and manage daily those outcomes and see where their opportunities are, but take action. Recommended actions is another feature of that approach.
Right. So getting to the core topic, you mentioned this issue of a patient not being able to pay for certain care, which relates to access to care and relates to the number one flashpoint in all of healthcare today, which is about healthcare insurance, what gets paid for, what does not get paid for. And so the technical term is denials management. And AI has become this other really hot item across all industries, with healthcare as a key area of focus because it's so important to all of us. This situation where a patient is being denied some type of service in healthcare or denied the payment for that service by their health insurance, wow, that's just really something that is misunderstood, I think. And also, in some cases, maybe the payer policy isn't as good as it could be. I don't really know. But talk about the application of AI on this issue of denials management. And then let's drill in a bit into that as far and broad as you'd like to go on how we should think about that as consumers of healthcare in the United States. Because obviously it's something that there was a lot of underlying angst that wasn't really being communicated through the biggest megaphone that it is now. But how can AI be applied to this denials management issue, and where does it go wrong? Where can it go right?
Yeah, great question. So let's maybe step back and talk about what does a denial mean, right? And then we can get into kind of what is the machine learning or AI impact of denials. So me as a consumer, let's say I had a disease and I needed a CT scan for that disease, and that CT scan cost $3,000. And I'm paying for my insurance, whether it's through my employer or if I was a Medicare through the Medicare process. And the doctor wrote and said, you need to go get this CT scan. I need you to go get it. I go into that office. I give them my insurance. I get the CT scan done. A couple months go by and I get a letter in the mail that says, hey, you owe $3,000 on this CT scan. Now, most Americans don't have $3,000 in their savings accounts to cover that event, right? So all of a sudden you go into massive anxiety mode. You're like, wait a minute, I pay for all this money for insurance. What happened? Why was this denied? And so then the consumers in the middle, they get this bill. They got to call up their provider, and they call their provider and they say, hey, wait a minute, like I got this CT scan. Why wasn't it covered? Why am I now on the hook for the full $3,000? And oftentimes the reason for that is that something got missed in the process.
And in that also, this patient got an explanation of benefits letter that says explicitly, this is not being paid for by your insurance.
Correct. We did not cover this because, right? And oftentimes the reason for that is something got missed in the process. Something didn't get documented. A step was missed on either prior auth, if it required prior authorization. But in the middle of that is a healthcare consumer that has a disease that needs a thing that is anxious, right? And it's not helping the equation of whatever the reason they needed to go get that CT scan for.
And the reason that it's not getting paid for in that example, which I think the example you're giving is one where it was appropriate to do that CT scan.
Correct.
The patient needed that in order to be diagnosed, and then they end up with the bill for it. And then as you talk about that, it makes me also reflect on just how difficult it then is as the consumer to do anything, to have some sort of recourse. So it seems as though things are just broken in the intake all the way through to the other side where you get the denial. And then what do? Call and wait on hold for 2 hours for somebody to get on the phone and tell you it wasn't covered. And their job seems to be to make it so it doesn't get paid for. It seems like it's a snowball.
It's a cycle of where the consumer's stuck in the middle. So they're often calling that provider. They're calling their insurance company. They're trying to broker the right information going back and forth. And it's a communication issue. And then oftentimes what happens, the provider then has to provide additional information to the insurer. So there's a whole nother level of process. And when you start to add up all the heads that are involved, call centers, front desk staff, providers, insurance staff doing the denial, insurance staff reversing the denial, it's a massive amount of labor that goes into just one of those. And it's happening every day en masse, right? So we're seeing in the industry, there's headlines almost.
It probably costs more to do all of that than it would have just to pay the $2,000. Potentially. And you're seeing in the industry, you're seeing where there's this sort of a intrinsic battle almost between providers and in particular in the Medicare Advantage space, where you're seeing denial rates of, call it, north of 50% in the MA plans. You're starting to see providers no longer take those plans. So what's happening is now you're having a reduced access to care for these members. So now we're shrinking their access to care and longer wait times for those members. So
what's happening in the industry around denials is really affecting the consumer. It's affecting you and I. It's affecting, I started off with my why with my grandmother. It's affecting people like that that get massive anxiety when they get these massive sort of EOBs and bills in the mail. It doesn't mean that they won't be paid at the end of the day. It just means it's going to create this long, cumbersome process. On the front end of that is also sort of the prior auth. So whenever we talk about denials, we should talk about prior authorization. There is a movement now to reduce the amount of things that need prior auth, but only for organizations that can demonstrate that they are very, very good at documenting the reason for services. So you're seeing almost like the Disney Fast Pass, right? For certain insurers, where they'll come and they'll identify a number of providers that don't have to submit prior auths for certain services because they've got those processes in lockstep between the two organizations and the two actors. But more than not, the process we just outlined is what healthcare consumers are going through. And it's created a flashbang point.
Right.
We're sort of in this inflection point where, if you look at medical trend, I think this year it's anticipated to be between 7 and 8%. One of the highest growths in medical trend in
7 and 8% of denial
of total medical spend. So last year, let's call it 100 million. This year, it's 7% higher than 100 million, right? In total medical trend. So increase in total healthcare dollar spend.
I see.
You as an employer.
7 to 8% total increase in healthcare spend.
Correct.
And that's year over year, that kind of compound
Is massive.
Is unreal.
Unreal.
I view this from an abundance perspective as I always try to. How can the future be much brighter than people think? Because right now, it's what you just said. The costs are going through the roof. The access to care doesn't feel like it's getting better. The ratings that we see about how we stack up versus other developed countries, all of these issues come together to make you feel pretty pessimistic. But this is a show that talks about how innovation happens when you align the right business concept and economic engine with some type of technology so that you can unlock this better future. Isn't it the case that, at least in theory, you can leverage artificial intelligence to do a much better job on the front end of ensuring that you get what you need, B, ensuring that the things that should be covered are covered, and C, identifying where there are gaps on the back end that need to be cleaned up that become more friendly for the user, right? Is there not some way to think about that? Or is that an area that you focus on where there could be a better approach to this, what appears to be right now a pretty dire situation?
Yeah, I think the answer is yes to that. So we're seeing technology move at a rapid clip, right, in the advanced, call it AI space. We've seen platforms like when OpenAI came out, and it wasn't that long ago that OpenAI came out. It feels like it was forever ago because the uptick in the uptake of adoption of OpenAI was rapid. Now you've got Microsoft that's partnered with them and bringing, the OpenAI large language models forward. You've got Google that's developed Gemini.
So really quick back on that point of OpenAI. Is it the right way to think Microsoft is partnered with them, or is it actually the case that Microsoft controls them as their AI machine and they are doing it in a really smart way to make sure that the regulators don't come down and say, hey, this isn't okay?
Yeah. My personal feeling is it's the latter.
That seems like it.
That's my personal.
And hey, good for Satya. What a brilliant move. Yeah. You talk about the judo move to end all judo moves. But anyway, getting back on topic.
Well, but if you look at like Jensen, the CEO of NVIDIA, and you look at some of his more recent talks, and then you look at Satya and you look at some of his talks, both of them have a common theme. The common theme is this concept of agentic AI, which we'll talk about, I know, here in a little bit, but where, traditionally as we've built healthcare, not just healthcare products, but we built any set of software or product, it's always had a database backend that's been very structured, that does a thing, it does a very specific thing, and that's it.
Yeah, it's more like
front end on it.
It's like the digital equivalent of a robot that was put on an assembly line.
Yeah. We'll
equate it. Repeatedly turns the bolt and checks the the seal or whatever and does that over and over and over again, it isn't going to dramatically deviate from that or improve itself on that. It'll just keep doing it the same way.
Right. I mean, simplistically, like we've all had vacuum cleaners for years. Before the Roomba and others came out, it required a human to push the vacuum cleaner to do the thing that the vacuum cleaner does. Now you have AI-enabled vacuum cleaners that roam around your house and they know where to go. They know where to
freak
stop.
out the dog, and sometimes they suck in the rug.
Sometimes they do things that, you don't want them to suck in, but
it's low risk, right?
Correct.
Like, if they get stuck in the rug, big deal. You get home, the floor is not clean yet, but it didn't kill anybody.
Yeah, correct. But nobody told it to go right, left. It learned, right? And so we're in this area now with this technology rapidly evolving where we don't have to tell the software what to do. We can feed it data and we can ask questions of it and we can get answers back without telling it exactly what query to go do and how to go get that information. That's a very powerful shift.
So isn't that a really promising answer to this whole insurance denials issue, where today it seems as though we're using these outdated decision trees that say, if this happens, then that gets denied. If that doesn't happen, then that gets denied. There are all these like hard and fast rules that don't contemplate the broader context or have the ability to ask a question and sense and respond and proactively go get to the bottom of it. So imagine if you had the equivalent of a team that was delivering on this analysis that represented you as the patient, that you knew for sure that things were happening to look into your best interests. So the bot was already responding and sensing and responding to wait, this doesn't seem right. And then going and cleaning up all this mess, which it sounds like a lot of it is manual data entry or data capture, that sort of thing. Why do I have to go sit on a phone? It's literally the case that we're putting satellites all around the world to make it so you're going to have instant high-speed internet everywhere through Starlink. And we can't make it so that a consumer can be represented by leveraging technology in a way that ensures if it should be denied, it's denied, but up front that was already figured out. Like, right. I just think that should be solved, right?
Correct. Yeah, absolutely. I mean, think about it we'll start with the provider and we'll work our way to the consumer, right? The average primary care provider, let's call it, has a panel of 2,000 to 3,000 patients. Most of them have around 2,600. Of those 2,600 patients, they have multiple insurers that they're dealing with, multiple disease states, and multiple sets of rules that you outlined. There is no way an individual provider caring for that many consumers of healthcare can remember all of those rules.
You said how many patients? 27?
Usually 2,600 to 3,000 is an average panel for a primary care provider. Specialists are a little bit different. But think about that. If you're caring for a tribe of, let's call it 3,000 individuals that have all kinds of different disease states, and you're seeing them on a regular basis, and you're ordering tests and you're ordering exams and you're wanting to keep them well. And oh, by the way, you also want to focus on well care, not just sick care. Keeping track of all that is insurmountable. And it's extreme. They don't have the resources. They don't have the time. The data might be there after they box clicked about 20 times in their EMR to put it in, which is a whole different set of issues. But this type of technology can go through and say, hey, I see you're about to order that CT scan that got denied earlier. You haven't justified these things. Can you please do that real quick before it ever gets denied, right? And so now I haven't set off all the downstream things we talked about with the consumer. I've got that taken care of up front, and I didn't have to have the provider try to go to the giant black box of rules and figure out what he missed or she missed.
So what's the impediment to making this happen? It seems like the technology's out there, that there are smart people who are motivated to solve the problem, but it just doesn't seem like it's getting solved.
Yeah, I think there's a couple things. One is, we're still in an era where there's a lot of data silos. I think, for all the regulation and all the things that are out there, for example, the information blocking components, we're still seeing data not flow quite the way it should within the ecosystem. There's a lot of agreements. There's a lot of red tape that goes into interoperability of data. So no one truly has a complete picture of me. I mean, managing my own healthcare, I don't think there's a single entity that has all of my data, that understands all the things that are going on. And even if they did, today the data collected on you and me in the healthcare arena is only a fraction of our total story, right? Like in previous podcasts that you've talked about some of the personalized medicine aspects. I wear an Oura ring, for example. My doctor doesn't have this data, but this data is all my sleep patterns. It's my HRV. It's my exercise patterns. Let's say I was diabetic and he was trying to manage my A1C better. Well, I'm going to have to tell him. What if I didn't tell him? What if that data could just flow to him or her, and they could leverage that data and they could see patterns, and intelligence could give them those patterns and signals, and they don't even have to sift through it and say, hey, you know what? I think I do want to make a tweak. I want you to try something different. They don't have that today. And so I think one barrier is the information itself. The second is regulatory and worry about bad actors. So I always use this analogy. If you're going to build a machine learning model to predict when planes crash, and you're actually going to let that model guide decisions of which pathway you're going to put a plane on, and if that model were 90% accurate, that means 10% of the planes that were in the inaccurate area would likely have a bad adverse event. If we had 10% of the planes in America crashing, we'd hear about it on the news every single day. That outcome for that algorithm is very, very high. Stakes are high. But in healthcare, I'm a nurse by background, as you know. We spend 30% of our time fetching and gathering things. If I built an algorithm that could reduce that amount of time in a very simplistic way and predicted, hey, Brian's going to need these 10 supplies today because of the types of patients that he's caring for, I'm going to go ahead and just send the supply chain robot with those 10 things before he ever asked for them. Let's say I needed 8 of the 10. Who cares about the other 2? I've gained an efficiency that's pretty massive at very low risk. And so the denials management space, I think one of the reasons we're seeing more uptick, but we quite haven't got to the full place that we'll be at, maybe 5-10 years from now, is there's this apprehension to doing more harm than good.
Right. So the concern is if we implement these technologies, they might run astray and cause a problem. And that problem could have really high consequences. And that reticence to lean in is preventing the application of this technology.
Right.
And then the data is siloed. You need the data in a more comprehensive way. But I think there's probably, this is an important point I have observed over my career, and the reason that I've executed my own strategy in the way that I have. I think too many people go after solving these problems around data with this view of getting all the data. And that's a death march because the data is captured in too many different places in too many different ways, but there's enough of a data set out there that if you train these models on whatever amount of data you can get, you can start imputing based on the data that you have access to what the likely scenario is. So for example, we've run a model that is at HC1 that's able to predict who is most predisposed to developing cognitive decline. And it does that based on lab values that have been fed into a model over longitudinally, meaning from as early as possible when a patient started getting tested on their life. Ideally, it's when they were born, which lab testing starts and continues. But then tying that back to claims and diagnostic information that tells you, hey, this person down the road was diagnosed with Alzheimer's, run a retrospective analysis and feed into the model on that patient's entire data set to say, what are the signals that start to be predictive of these future outcomes? And then in the future, you're able to use what you can access, which in that case is the lab information, even though you don't have their comprehensive record and you don't have everything from everywhere. So there's probably some opportunity like that as it relates to AI to advance this issue around denials management. But it seems like if you were going to place your business focus on one part of healthcare, it would be on this issue of what gets paid for, how the communication and data gathering happens from inception to payment or denial, and push everything way closer to the front to where there isn't this surprise downstream.
Yeah.
Nobody likes to be surprised. It's
Right.
It's like the surprise bill as a business owner that you get this giant surprise bill from a law firm or from some other, your premiums go up way more than you thought. And all of a sudden you're sitting there going, what's happening? Nobody likes surprises. So it seems like the application of AI to the business of healthcare to dramatically improve this process, the stakes are sort of highest there. Because if there's no effectiveness or confidence in the economic side of the healthcare delivery model, how can you have confidence in anything else?
Yeah, no, that's exactly right. So, we're focusing our initial efforts on the key area of why might something get denied?
And this is MedeAnalytics.
Correct, at Medi, yeah.
Okay.
What are the probabilities of this getting denied and why? And I think that last piece is really important, right? With anything within any sort of predictive approach is it's not good enough just to say, I'm 90% confident that this is going to get denied. Good luck. Like, okay, so what should I do about that? Why do you think that it's going to be denied? Is it missing documentation? Is it an inappropriate test for the disease state? Have we not documented the disease that the consumer has accurately? Is it something else? And so we've focused our AI capabilities initially in the denial management space on that core question. Allowing the clinician
what's going to be denied and why it's going to be denied. And does that happen then in this new design early?
Yes. So it's the sooner you can get up the funnel, right? So you can provide that to an insurance company, but it's already happened, right? So being able to say to an insurer, hey, the 90% probability this claim is going to be denied. Okay. But providing that to a provider on the front end, as soon as they go to click the box to order a test, is where you want to be, right? To say, hey, this likely is going to have an adverse effect in a denial. Assume the clinician makes the decision whether it's legitimate or not. No algorithm should make that decision. But because we think it's going to get denied, here's why we think it's going to be denied, and here are the interventions that you should consider doing about it, whether that's that provider or the front staff or whatever. If you can prevent that downstream denial for that consumer, things just work better, and including timely access to care.
Just eliminating all the administrative costs and overhead that happen when you have all of this back and forth and call center and the patient pain. So the future is bright on this front. It's just a matter of getting enough adoption of and modernization around how this is managed. And really on the front end saying there aren't that many different potential paths. The one is this is going to be paid, because it was approved and pre-authorized and the documents are there, and so it will be paid. The other is it might be paid, but we need more information in order to do that. And then the third is it's not going to be paid, and here's why.
Exactly.
And that should all occur up front. And when that occurs up front, then there's clarity. It eliminates the surprises. And this is one of the examples of the promise of AI. I think a lot of times when people think of AI, they think about the humanoid gone wrong or the HAL 9000 in 2001: A Space Odyssey, where, wow, what if it doesn't work? And the stakes are so high. And then ultimately we end up out there dissipating in the stratosphere of some random planet.
Yeah,
because
it's like we grew up on the Terminator movies, right? It's like
right.
Giant Arnold Schwarzenegger's on both sides of the fence.
Fighting, yep.
Yeah.
Which also brings up this other point we talked about that was provocative, where on one side you've got the insurance company's algorithm that's looking to be very tight on denying anything that ultimately is not completely perfected. On the other side, you have more of the patient represented on, I need to get everything paid for that I need in my healthcare. So perhaps there is some future dystopian place where now we have these bots that are fighting each other.
Yeah. I mean, we were laughing about it, but it's very true, right? Like,
Imagine that debate, right?
yeah,
Imagine that.
So you've got a denial bot on the insurer side, you've got a prior auth bot on the provider side, and they're going at it, right? And so you've got to. That's the concern. Right,
it's those like War Games. That was the other movie.
War
If you're
Games,
old, you remember War Games.
Right. I remember
He'd
that.
put his phone on the modem and dial in, and somehow he took over like the Russian military.
Yeah, would you like to play a game, Professor Falcon? Yeah, absolutely. Yeah, it's that kind of concept.
I need to rewatch that.
Actually. Yeah, that's a good movie. I haven't watched it in a long time, but it's that.
How do you know you're a nerd? It's when you love War Games.
When we can have this conversation. Yeah. The concern is that you're going to start to see that. And at the end of the day, the concern is that the provider loses, the care providers lose, and the patient loses in those scenarios. And so the organizations that are starting to adopt this early and well are ones that are not only creating the AI and leveraging the intelligence, but putting the proper processes and balances and checks in place. It's like cybersecurity. So we have to assume that the bad actors have the same technology as the good actors. So you're seeing an AI.
Well, I think there's another analog, which is in the advanced smart contracts area of crypto, like Ethereum is designed to have these defined smart contracts so that payment remuneration occurs when all these things are met. And that should be how we build into the payer process these smart activities where it's not this like form that you don't even know the answers to 5 of the questions.
Right.
I just went through this with a new life insurance policy where there were these questions I had to answer. I had no idea what the answers should be. It wasn't about my health condition. It was like, what very specific nuanced things do you want to have in what way in your insurance? I'm like, I don't know. Actually, it may have been, anyway, it was some insurance questionnaire. And I'm relatively educated and, had no clue what the hell it was supposed to be. So I think there is a solution. It's not simple, but I think also it could be simpler than what a lot of people are making it. Now, solving for the denials management process is a huge opportunity. It sounds like Medi's on a great path to make a huge impact there. And we should find ways to collaborate too between our companies. I think we have a shared vision for how do you maximize outcomes while also boosting the bottom line of healthcare, because ultimately a healthy bottom line makes it so patients get better service and better access, and everybody behaves rationally. So we should keep that going. Now, there's this whole other topic you brought up, though, if we could just for a couple of minutes, related to AI and agentic AI, which for the audience that may not be familiar with that term, agentic, it's really the concept of an action that can happen in a more dynamic way based on what's uncovered. So it's not just an analytic that says, here's a data point or a trend. It's not just an AI that says, hey, specifically, this is the thing that can be done. It's the ability to sense and respond and change like a human brain can. That's more like the agentic concept. And I don't want at least, an AI at this point taking the place of the doctor and having, some people refer to them as hallucinations, but basically drifting away from the ideal answer. It's like in the case of ChatGPT, it's not always right, but it always sounds sure.
Right.
That's the dangerous part, is when you see the way it interprets and answers, you think, hey, this is like what a human's brain would do. And you could think the same way on the surgery table, and that brain has been fed the wrong information, and it all of a sudden takes out, the wrong hip and replaces it, and then it turns out that it was the other one, and they took out your good one. And that's an example of something that could happen. But on the other side of the ledger, you said 30% of a nurse's time is spent fetching and gathering, which is a low value task that's required. Or you talked about the example of the room is ready for the next patient. The bed has been made, things have been put in their place, whatever that cleanup process is. Talk to me about agentic AI applied to that kind of a concept.
Yeah, I think that, so the concept of agentic AI, you're spot on, right? Like, I think if you've ever seen like the sci-fi movies where they get in the medical pods and the medical pod does a full surgical procedure, no human involved, right? That's the fear around these AI type capabilities today.
I always wonder about that scene in the Star Wars movie where Luke is out on that Tauntaun and he's on that frozen planet and gets thrown off and ends up, who shows up and cuts the Tauntaun open and puts him inside of it in order to keep him warm? Do you remember that?
I think I remember the scene. I can't remember who it is.
I think it might have been Empire Strikes Back.
Yeah.
And then he ends up, though, back in this pod thing on the spaceship.
Yeah.
And now that you say that, I think probably that pod was doing
like a medical pod. Like the movie Interstellar has a medical pod.
And it's some kind of a fluid is inside of there. So maybe that's the future, is AI-informed, smart nanobots that are in the fluid.
There you go.
That are just getting to every single molecular level of fixing everything.
Yeah, we've come up with a whole new business
model. And then we can live forever.
Yeah. This is great.
We can raise money for this. No, just kidding.
Yeah. We'll go do that.
So that's on the other side of the spectrum.
In the meantime, let's figure out how to get the beds made.
Okay, so how do we make the beds?
So this concept of agentic AI. So if you sort of took it, no matter what role you play, whether it's healthcare or it's finance or it's manufacturing, and I think the manufacturing industry has been at this a lot longer than the healthcare industry has. Look at every task you do, and oftentimes a good percentage of it are mundane things that are low risk type tasks, scheduling meetings, scheduling a patient for an appointment. Gathering supplies in the example that I mentioned earlier. Very low risk, high repetition tasks that are often being done by some of your more expensive labor resources, which is the first or second highest P&L item to any healthcare organization.
How about the example where you're pre-surgical and the surgeon has a specific setup they're expecting on their tray that they use?
Yeah.
That seems like a great example where the impact is high in terms of efficiency and clinical outcome, and where a bot could probably do that better and never get disenchanted by doing that over and over and over again and be tied to the profile of the specific surgeon. So if you had an ambulatory surgery center, whatever surgeon was in that room, you had their profile, and the AI bot that had learned that over time would just set it up perfectly and have sensors that fully understood the way the room was set up and could track where things went and how they worked. Maybe that's also a midpoint between the cleaning the room, which is a no-brainer and very low stakes, especially if it could sterilize better and avoid spread of germs and so on, which maybe that's even just the specific one, have robots that sterilize the room, right? All the way, though, to clinical where the machine is doing the work, which I think is not anywhere near ready, but in between, it's getting things set up so the surgeon can be more effective.
Yeah, no, that's a great example. So, I mean, when EMRs became a thing, right, preference cards are what you're talking about. So a preference card drives the instrumentation, the things that go on that sterile field in an OR situation. Well, each physician has a little bit of a different preference. And so what happened when electronic medical records really became a thing is when you started to look at all those paper preference cards that had to be managed, there were thousands of them. I mean, a healthcare system I worked for, we had over 5,000 different preference cards. And those are unwieldy to manage. So what happened was all of a sudden we would go to those providers and say, you know what, for a cabbage, I used to work in a heart program. For a cabbage, we want one preference card. You guys got to agree. Well, they never agreed, right? Because they all had different flavors. An agent could essentially look at the patterns and outcomes, not just the patterns of the provider, but the outcomes, and say, I think you should use these things. So I'm going to go ahead and just set these up, right? I'm going to go ahead and order these to the supply, to CS, have it ready, optimize it, and go.
And another dimension of that, and we're addressing this with 3Aware, is the analysis of the effectiveness of one or multiple devices in a truly objective way, where are you getting the best outcomes?
Right.
Which stent do you use in which scenario?
Correct.
That's something that today is very much subjective, because it's the physician saying, no, I want to use this device. I'm used to that device. And the health system saying, no, we need to standardize. We should use this other device because we got a cheaper price. And the doctor's saying, that's not the one I want to use. And ultimately, the outcome downstream isn't connected from a real world evidence perspective in a routinized way that can be calculated.
Right.
And so it's just a lot of subjective discussion. And oftentimes it's the sales rep from the medical device company that takes the doctor golfing the most, or takes them on the annual trip to the beach, is the one who gets the order. Yeah. And nobody really knows for sure what's the best outcome.
Yeah.
So
yeah.
Look, Brian, I wish we could keep talking for another 2 hours, because this has been absolutely awesome. We should have the conversation more frequently. Would love to ask you if there are any closing comments you'd like to make about the future of healthcare, the business of healthcare, and how AI can be applied to fix these issues, from denials and that huge flashpoint all the way through to how do we get the bed made?
Yeah, I think the point that I like to leave with everybody is just, start simple, right? Don't try to. A lot of organizations want to go to the most extreme case of using machine learning, and probably one of the more risky, which is on the clinical care side. There are plenty of use cases that are, as we've outlined here, that can be extremely beneficial to the healthcare ecosystem, including the consumer, that are a lot less risky and a lot more simple. And so if you haven't already got a strategy, start simple. If you haven't defined your strategy, you need to define it. And if you don't have the right partners, then, call us, right?
Right. And get some wins. Get some wins.
Get some wins.
And there are practical ways to get wins. Another one is staffing optimization. We talked about earlier, where we're using AI to optimize the match between what's needed from a diagnostic testing perspective and the skill sets of the staff. These things can be done today, and they dramatically improve the delivery of care while making the healthcare system more efficient and more profitable. And now's the time. We've got costs going up 7 to 8%. It's just not sustainable. So thank you so much, Brian Norris from MedeAnalytics, for being on Boombostic Health and being a friend of the show. Look forward to continuing the conversation. Would love to have you back on sometime. And let's find some more ways to collaborate.
Yeah, that'd be great. Thanks, Brad.
So we're going to now transition to the verdict with Emily, where we'll talk about some of the regulatory and legal considerations of applying artificial intelligence to issues such as denials management. We'll see you soon. Well, here we are with the verdict with Emily to talk about the conversation with Brian Norris, head of strategic consulting over at MedeAnalytics. Emily, welcome to Boombostic Health for another episode here. I know you were listening in on the conversation with Brian, and the promise and perils of AI really are something that's still a bit of an open question. People are saying, can AI revolutionize healthcare? And asking a lot of questions about what is appropriate and inappropriate. And certainly central to that is denials within the payer space. But there's quite a bit of litigation that's emerged from all of this. Is that accurate? Could you give us your point of view?
Yeah, I think actually people are mostly familiar with the concept of denials, either personally, but also in light of the UHC CEO's murder a couple weeks ago. But the litigation actually predates that. At least as far as I'm concerned, the biggest case that I'm aware of was one that was filed against UHC in 2023 by families of 2 beneficiaries who had passed away allegedly because claims were denied, which precluded their ability to get medically necessary treatment. That lawsuit claimed that UHC uses a AI algorithm to either approve or deny claims. And the algorithm that they allegedly use is perceived to be flawed. The denial rate associated with the AI is alleged to be at 90%. So 90% of claims that are submitted and go through that algorithm are denied. And there was a secondary study that was done, and this is all based on what I've read with respect to the lawsuit. I'm not part of the lawsuit. But from what I've read, the secondary study found that one of the factors that UHC looked at was a beneficiary or their family's likelihood of appeal and what the success rate would be with respect to that appeal. And they found, I should have fact-checked this before we started talking, but the appeal rate was somewhere between like 0.2% and 2% of folks would actually appeal it. And the reason for that was either they just didn't know how to do it, or they didn't have the financial ability to pay for the appeal, didn't know, and so they were more likely to end whatever the treatment was that they should have been getting as a result of their provider's determination, but were denied coverage by the insurance payer.
And this is still being litigated.
Correct. Yeah.
And so what you're citing is just what's in the public domain about these particular cases.
In the public domain, and then what I've read from the complaint. Yeah.
Right. Okay. That's interesting. So, gosh, if that's true, it's pretty powerful stuff that backs up a lot of the animosity that's out there.
It does. And I know UHC isn't the only one that uses an algorithm, and I cannot say whether their algorithm is correct or incorrect. Those are just the allegations. But yes, if they knew that this algorithm was flawed, even in a limited capacity, right, that resulted in denials of claims for medically necessary services that caused harm to individuals, there could be significant liability there for UHC.
Right. That's fascinating. I was not familiar with that litigation, and really interesting to learn that. So if you consider a business that's getting into this space of trying to make claims management better, how can you, in your view, and this is just our opinions, obviously, but apply AI technology to enhance the outcome, but avoid this type of a rogue application of the technology? Any thoughts?
Yeah. So, I mean, the reason that UHC said that they went down this algorithm path, this AI path, was because it could increase efficiencies by like 50 to 75%. I think Brian hit on this when he was speaking. I don't think we're quite there yet to have AI replace humans. So you could still use the algorithm that exists, presuming it's not flawed, but have some sort of independent fact check verification process by a human who actually looks at the medical records, the results, or not the results, but the orders to determine based on a person's condition whether service is actually medically necessary. The problem with that, though, is somebody who deals with insurance carriers all the time. The people making those decisions at the insurance companies aren't always the most qualified. And my partners and my clients hear us say this all the time. Just because something is clinically medically necessary doesn't mean it's medically necessary from a payer's perspective. So what a payer determines to be medically necessary is completely different than what your doctor says is medically necessary. I mean, take a look at like preventative care, right? Your doctor will tell you till he's blue in the face that preventative care and genetic testing and all of that is medically necessary because it's going to improve your lifestyle. You can start making proactive instead of reactive decisions. But the insurance industry says, well, that's not the way our business is modeled, and so we're going to deny that.
Interesting. So is there an opportunity with AI to bring those groups together potentially? And you mentioned the problem of just human horsepower and expertise. There aren't enough to go around. I think the promise of AI, in my view, in healthcare isn't to replace the humans, it's to power up the humans. I've used this term bionic. You make it so the people who are doing the work, the experts, can focus on those high value decisions. So there's this idea, this concept, technique of reinforcement learning through human feedback, where you're identifying these potential anomalies and issues and surfacing those to the experts that can make the decision. Because I would contend that the reason there aren't enough people to go around is because everybody has to look at everything in order to find anything. And so you end up diluting all of the people so that the experts really, you can't tell if they're focusing on the right best thing or not. And then you end up with way too many people doing work that they're not qualified to do. So potentially that's the answer. And hopefully through what sounds like was a really, regardless of whether or not the algorithm's the reason, it's a tragedy that somebody could potentially lose their life because of the fact that service was denied that was necessary. But I think if you consider the possibility of infusing this technology into a human process and having the human who is qualified verify, inspect what they expect, potentially that gets you to a better outcome where you at least reduce these kinds of errors.
Yes, I agree. And the corollary to that is switching to value-based care as opposed to fee-for-service, right? But we've been talking about value-based care for years and years and years. And
hey, it is happening. It is happening. It's just not pervasive.
At a glacial pace.
And certainly in the laboratory segment of healthcare, where all diagnostics at some level run through lab, that's an area where directly making payment for the testing doesn't have a value-based care approach yet. But with technologies like we're doing at HC1, where we're connecting the dots and analyzing the relationship between the optimal diagnostic approach and what that does to the cost of care based on a better outcome, I think that starts to tell the right story.
Yeah.
Because I think that right now the fixation has been on how much does it cost to do the test? How much does it cost to run the image? How much does it cost to look at it? That's not the big cost. How much does it cost for a pill? That's not the big cost. It's when the person ends up in the emergency room because they got the wrong diagnosis or a misdiagnosis, or they end up with a chronic illness and require an amputation or whatever that is, lifelong. Ultimately, the most expensive is when somebody needs around-the-clock care because their health has deteriorated to such a point. So it's interesting because healthcare is so siloed that we view these things as their own little compartments, but in reality, it all hooks together. And that example of you saying the payer's view on what's medically necessary differs from the caregiver's view on medical necessity, that I think is at the core of all of this issue. Yeah. Everybody should be playing on the same team in a coordinated way, but they're just not yet. But value-based care, I think, is the answer. It creates the right incentive. And, you know, Brian brought up a really good point that even in value-based care models, there is a fee-for-service component.
There is, yes, that is true.
So it's not this mutually exclusive thing.
Correct.
So, well, thanks so much for sharing this eye-opening information about these lawsuits that have already been out there. And obviously the tragedy of the United Healthcare CEO being killed, there's no way to justify that in any manner.
Right.
And just absolutely is devastating that happened. And I can only hope that, and we can only hope as a collective healthcare expert group, that in the future, the payer approach can become much more transparent and inclusive of the patient, the beneficiary, so there aren't these surprises that lead to potentially terrible outcomes and also just a lot of consternation. So thanks a lot for being on the podcast and bringing all this knowledge to the table about the legal and regulatory implications of our guests. And thanks again to Brian Norris from MedeAnalytics for joining us. Have a great day. See you next week.